Good afternoon, Nevada County. This is David Carroll from the Nevada County Tech Connection. I'm here with Kimberly Parker.
Hi, I'm Kimberly Parker, Executive Director of Sierra Nevada Memorial Hospital Foundation.
We're here to talk a little bit about technology at our local hospital. Very excited for a longer talk coming up in September. This is really just a little teaser tidbit for all of you fine folks out there to enjoy. Now, everything has changed in the last few decades when it comes to technology, but how
Absolutely.
specifically has the hospital changed and adapted?
Well, I've been at the Hospital Foundation for a little over 20 years, and I have to say one of the biggest areas that has advanced and changed is technology. Not only technology within equipment, and Linda Waring, the director of our Diagnostic Imaging Center, will be joining the Tech Connection group in September to talk a little bit about the technology behind the diagnostic equipment within the hospital. But probably the greatest area that we've seen, growth is telemedicine. When I first came to Sierra Nevada, there was no real telemedicine as we know it today. And it's become much more common. And the one thing I will say is that I think a lot of people think of technology and think of telemedicine as being something that's only pushed out to rural communities, but actually telemedicine's being used quite a bit in the urban areas as well. And so over the years, we've been very fortunate to add a number of areas of technological telemedicine up here.
So, to rewind a little bit here, what kind of specifically is the idea of telemedicine? Who does it serve? And a little bit of what are its limitations?
So technology, I think, in medicine probably very initially started with rural communities in mind, because there was the idea that not all rural communities could have the physician population that it really needed in terms of some of the broader areas of healthcare, the specialties areas of healthcare, and telemedicine was a way to bring that in. However, I think what has happened over the last couple of decades is specialties in the hospitals have changed dramatically, and by that, our hospital CEO Brian Evans had a great slide that he used to use when he did presentations, and the slide was just filled with words, and the words were very, very tiny all the way across. And what it was meant to represent was all the specialties that were in hospitals nowadays. And those specialties, he went on to point out that it didn't really matter anymore if you're an urban hospital or a rural hospital. No hospital can be all things to all people. And that's when telemedicine started, I think, to really take a broader kind of approach, which was, if I'm a hospital and I can't be all things to all people, whether I'm in an urban or a rural area, I still may have cases in an area that I don't have a specialty. And how are we going to have access to that in the best way possible? The way that, and I'm not, I've said I'm not a technological person, excuse me, so I'll probably explain it in what's very basic terms, but really for us, the first technology started with a telemedicine robot. And even the look of the robots has changed, but our first approach, and Gil Matthew, who's very involved with the Tech Connection, actually, interestingly enough, was the chair of our Stroke of Luck campaign, which helped bring the first telemedicine to Sierra Nevada. And the idea is that it was a robot that, and we raised money to bring this to the hospital. Technology, telemedicine's fairly expensive, initially to set up. Back in those days, at least it was. And the robot at that point, basically, it was on wheels, it could move, it had kind of a big screen on it, and it would roll up to the patient, and what we deemed was our first most important arena for telemedicine up here in Nevada County was stroke,
Mm.
because stroke is one of those things that you don't want to be far away from getting immediate care. And while we had a neurologist up here, um, that neurologist couldn't be 24/7, do all, her practice, do all the hospital call night and day and everything. And so the idea with telemedicine, and we work out of a telemedicine IT arena that's down in the greater Sacramento area that kind of connects all the telemedicine for all of the Dignity Health hospitals in the region. And the idea then is that the hospital sets up the robot, purchases the robot, but then in telemedicine, you have to contract with the physicians on the other end. And in this case, of course, they were neurologists. And they contract with you as if they were at your hospital. So you have to go through provisioning, you have to go through legal, you have to go through all the methods of how, they're going to be paid and all that. And what happens then is 24/7, when there is a telemedicine need for stroke at our hospital, and the case of this early starter for us, is someone would come to the hospital, they would present with stroke symptoms. If the neurologist was there, great, but if not, they would immediately use the robot to reach out, would connect to the physician on the other end, and that physician then could connect to the patient. And one of the things I think we found very quickly with that particular situation, and I think other hospitals would say they found very quickly as well, and that was the key advantage with the telemedicine robot was that we could actually get the physician on the telemedicine robot faster than we could physically get the physician to the hospital. And so the care, especially for something like stroke, which you want to be so immediate, the process of that could start so much quicker because the result of getting the robot connected to the patient was so much faster.
And especially in Nevada County, where let's say your neurologist lives up Highway 20 and it's snowing. Yeah, I could see.
Absolutely. Absolutely. And what people don't realize is that you don't just have the ability in telemedicine to have, as an example, a robot and use it for anything and everything. For every single specialty, you have to have a different contract with a different physician group. You have to have, it set up in a way that the telemedicine, works for that particular area. And so sometimes people will say, well, why don't you just do telemedicine for everything? Well, unfortunately, it doesn't work that way because there's a lot of kind of behind the scenes size. Now the robots themselves have changed quite a bit over the years. One of the funnest things, and I regret that I don't, I'm not physically located at the hospital, so I don't have the robot behind me, but I have had the robot, come in, to various meetings. And so maybe, who knows, maybe when Linda's doing her talk, we'll have the ability to have a visit from the robot if she's doing it from the hospital. But the robots have really advanced themselves. And one thing I really didn't mention that I will say is that, interestingly enough, and I think people probably who are doing Zoom a lot now might be able to relate to this a little bit, is people would say, don't people feel strange talking to this robot? And it's one of those scenarios that because you have this physician and they're up close and they're talking directly to you and you're seeing their emotions and all of that, the screen kind of disappears pretty quickly and you feel like you're having that direct conversation. But since those times, things happen like the robot, you can do different tests like an EKG on the robot now. It can check your blood pressure. It can do other kinds of things depending on what the need is and what the robot has. And those tests that you do not only are available for whoever is at the hospital. So for example, if you're in the emergency department, you might have a great ER doc there, but he's not a neurologist, but you still want him to be able to look at the results of your tests. So the ER doc can not only do that, but the the tests also go directly to who's on the robot. And so they're seeing those results on their end. And then the other thing, which some people might think is a little freaky, but it's kind of fun to watch, and that is the physician can actually control the robot. And
Mm.
so, for example, we now have a robot that is up in our ICU, our intensive care unit, so that there's constantly a physician, that is there. And we do have hospitalists and other physicians that regularly round and go into the ICU, but at least once a day, and I've had this happen to me, where you'll be up in the ICCU and you'll be walking around and all of a sudden you'll hear something wheeling towards you and you turn around and it's the robot and there's Dr. So-and-so there and he's like, hey, how are you doing today? And he's just kind of rolling himself around and he's going into patient rooms and checking on patients and talking to the families in the room. And it's kind of amazing, how far that's come. And it's been, telemedicine is, I should say, while, you're seeing it a lot in hospitals, you also are starting to see a lot more telemedicine in clinics, in, some physician offices. And of course, now during COVID-19, we're starting to see a different kind of telemedicine, which is the patient to doctor telemedicine that, as people were unwilling and unable to go into a physician office during COVID-19, physician offices have set up more and more these abilities to have kind of these, private Zoom consultations. It is often, a little different kind of a setup because, as you can imagine, because of HIPAA, the Privacy Act, they have to be able to set these things up in a way that patients' privacy is protected but there's a lot of talk. There have been some statistics out there. I think at one point I saw a statistic that was something like during COVID, 60 to 70% of patient visits with physicians had gone to telemedicine. And so I think after we get through all this, it'll be interesting to see where people's comfort levels are and if, a lot of people are comfortable for, simple things, continuing to do those telemedicine visits, or whether people feel that they really do want that personal touch of going, back into a physician office. These have been interesting times that I think telemedicine has exploded in a way that probably wouldn't have happened if we didn't have a pandemic going on.
How has the fact that there's been less patients coming into the hospital affected the hospital? Has that helped? Has that
No, and I will say that it's changed, more recently. I think when COVID first hit, first of all, when COVID first hit, all hospitals pretty much canceled all their electives. No one knew what to expect, and we still don't, quite frankly. I think what happens is we get lulled into these senses of security. But I was just looking, while our numbers in Nevada County continue to go up, I think as of last time I looked, we were well at the high 300s, and Western County had surpassed Eastern County. In terms of our population, our numbers are not as percentage-wise challenged as some other communities. But I will tell you, Sacramento right now is just getting hit very hard. Just within the Dignity Health system, I think I saw yesterday, it went from like 300 and something to almost 800 just in the one day. And so, we're not out of this, but hospitals have learned how to do a whole lot of things. And one of the things I do always say to people, because a lot of people were avoiding, initially people couldn't go to hospitals for elective kinds of things, but they were avoiding them for emergency care. And that was really dangerous for people, and something that we really worked very hard to get the communication out that the hospital is very safe. And one of the things I always tell people is hospitals are always there to deal with infectious disease. Now, this is a different kind of infectious disease that we've had to wrap our hands around how we're going to deal with it and learn as we go and all. But, you know, the staff have all been trained to deal with infectious disease. But I will tell you that now I think the hospital is, you know, certainly is one of the safest places to be. I would not hesitate to go to send my children, to send my loved ones should they need care, especially if it was acute, critical, or emergency care. There are very strict visitor policies. There's certainly precautions within the hospital of masking, of sanitizing, of all of those kinds of things. If you're going to have an elective procedure, you have to, you know, you have to be tested in advance and such. So all of that's in place. But hospitals in general in Sierra Nevada as well took huge financial hits by losing all of their elective surgeries and other kinds of normal patient care that they, you know, would count on during those months. You know, when you're not doing any surgeries, and you know, it affects the hospital, it affects the physician offices, et cetera. That being said, you know, there has been some CARES Act funding, you know, that has been released to hospitals, and Sierra Nevada is okay and is in, you know, decent shape, because we actually received CARES Act funding that was given to all hospitals initially, and then Sierra Nevada qualified for a second round of CARES Act funding, which was very specific to rural hospitals and rural communities. Now, again, we don't know what the next few months are going to be, and those funds have to last at least through December. But we're in a good position with supplies. We're in a good position with preparedness, and we haven't had a tremendous number of cases, you know, that have come through the hospital. More has been like one-offs that have, you know, come in. So, you know, I would encourage, you know, people that, you know, need any kind of care. And I think most of the doctor's offices, quite frankly, have figured out how to keep their offices safe as well, whether they're having you wait in your car till your appointment, or, you know, they're temperature checking or whatever they're doing when you come in the hospital. But yeah, I think ER visits went down nationwide like 65 to 70% during the first couple months of COVID, primarily because people were afraid, you know, to go into a hospital.
Now, some of those ER visits could be addressed through at-home patients' telemedicine, whereas others, like the case of a stroke or a heart attack, you want people to be coming in if they're having symptoms.
You know, what I mean, and it's true for ERs in general, because the way that emergency departments are regulated, the cost of care, both for a hospital and for physicians and for a patient, is more expensive in an ER. And people don't always understand that they are regulated to staff in a certain way that is different than, you know, other areas of healthcare. And so you really should only go to your ER if you have acute critical, you know, needs, because it is going to be a higher cost. So, you know, I encourage anybody who has other kinds of just more routine kind of health concerns, you know, your physician office, you know, one of the clinics, you know, are always probably the first place to start. And if they feel that you really need more emergency care, you know, they'll certainly direct you there. But if you are having, you know, if you're having respiratory breathing, or you have chest pains, or, you know, any of those kinds of big issues that do need to be, you know, seen in an emergency department setting. And while it's not used for critical care, but for things like if you've really, you know, if you've done something and you're concerned you have a broken bone or something, a lot of people don't realize if you go on the hospital website, there's a program called In Quicker, and you can actually schedule an ER visit. They show you the open slots. And so you can sign up right there. And so you don't necessarily have to sit in the emergency department 3 hours waiting. You can kind of say, oh, there's an 11 a.m. I'm going to sign up. Now, what I always do caution people and say, emergency departments are always going to take care of the most critical cases first. So if there's an accident on Highway 49 and you've got your 11 a.m. and that accident's coming in, they're obviously going to take those, those people first. But for a lot of people, it just, it lessens the need to kind of just sit in a waiting room there. So especially during something like this, it's a good way if you have to go to the ER and it's not critical or acute or, life-threatening, that you can do it without having to necessarily sit in the waiting room.
That's a very, very cool little side topic I'd like to delve into just for a minute here. Is that appointment system, is that new to COVID era, or has that been something you've been rolling out for years?
Yeah, it's been there for a couple years. The hospital launched it a few years ago, and then quite frankly, there were some glitches in it, and so they kind of took it off for a period of time till they got the glitches worked out, and then they put it back up. So it's been up, I think, again for a couple years. It's just one of those best kept secrets that, I try to put out in the union, or I try to make sure that people know about it. But, it's one of those things that, it's not top of mind if you don't need it. So, it's just kind of, I just constantly like to keep saying it. So hopefully it just sticks in someone's mind. So someday when they do have that emergency situation, they go, I think I heard about something once at the hospital and they remember it.
It's just a perfect example of how tech slips into every aspect of daily life.
Absolutely.
It's not the doctor, it's not the tool, it's not the medicine, it's scheduling what time you're going to be there. And you don't even think about it, but that could make it so much easier and take a lot of the stress out of, oh my God, I broke my finger. What am I going to do?
Absolutely. And, some of the clinics, are able to handle a little bit more, now too. And so if you're used to going somewhere like Ubidocs or something too, or even your physician office, and you think, this is kind of routine, but I don't know if I need to go to my doctor in emergency room, I always suggest make that call, because sometimes I think a little bit more often you'll find, oh yeah, I can go over, and they said they can do it in the office. And again, wherever you can do that, you really do want to do that, because you're gonna find that your cost to have that kind of a service done in a clinic or even your physician office is going to be less than having it done through the emergency department. And quite frankly, we want to support our physician community by making sure that they have the business to keep viable and strong as well, especially during these times.
Yeah. Let's see. We've covered a lot of what I wanted to address today. I guess we talked a little bit about the diagnostic imaging. You just just briefly a little kind of preview of what we might hear Linda talk about, or no?
Yeah, no, what I can say is, again, in my 20 years plus, diagnostic technology has changed so much. And she's probably, I haven't talked to Linda about what her talk's going to be about exactly, but I suspect she's going to talk about CTs, computerized tomography, and MRIs, and nuclear medicine. And we have an incredible linear accelerator within the cancer center. She might talk about we have a simulator that is kind of for pre-testing within the cancer center, and how some of this technology has replaced things that, quite frankly, used to take a long time either in surgery, and by that our radiologists, they've moved more towards interventional radiology as an example. And interventional radiology is, a way that they could go in and do something that used to have done by surgery, quite frankly. So it's less invasive, it doesn't take as long, it's not as hard on the body. And while everything certainly can't be done that way, technology has moved us, more in that direction to be able to do some of those things. Also, there's all of the wonderful equipment that we have in our Women's Imaging Center, mammography, et cetera. The foundation is just raising the final funds to purchase a brand new mammography unit for, for the Women's Imaging Center. And so I think you'll find it's a fascinating talk. Linda's a fascinating gal. She's got about as long a history, with her work at the hospital as I have here at the foundation. We kind of grew up in our roles together, and I encourage everyone to join for that. I think they'll really enjoy it.
Should be a great talk. It's going to be on September 15th. You can watch it on the Nevada County Tech Connection YouTube channel, right where this video is posted.
And I would just say that, if people think of things that they might want to know about in advance or have questions about, my email is Kimberly, Kimberly, .Parker, Parker, then the number 1 at dignityhealth.org. If you just send me your questions and such, I can pass them on to Linda. And if it's something that she can include in her talk or talk about in a little bit more detail, I'm sure she'd be very, very happy to do that.
Fantastic. Really looking forward to it. Thanks so much for your time today, Kimberly.
You
Do you
bet.
have any last thoughts you want to leave us on?
I will just share the one thing I did not, say to the group at the beginning. I have been on the ERC board for well over a decade. I was the past board chair. It's been really fantastic to see the birth and development of the technology group. And, I'm so thankful that you guys, are meeting and have the great work that you're doing on behalf of our community as well. And I look forward to hearing more about other things that this group is interested in the future.
Well, thanks so much, Kimberly.
You bet. Take care.
You too.